Okay. So we talked about the first part of this chapter about the integument itself and the two layers, the epidermis and the dermis. We talked about the different functions, characteristics, what you'll find in those layers. We briefly discussed the subcutaneous layer, also known as the hypodermis. What's one of the major concepts that I said about the subcutaneous layer, the hypodermis? What did I say? Nailed it. It's not part of the integument, right? So make sure that you know that. It's a great true-false question there. So this next part that we're going to be talking about our nails, hair, we're even going to talk about some of the glands. All of these structures are what we refer to as epidermal derivatives. And so essentially what had happened was these structures that we're going to be talking about were once part of the epidermis. Can't talk tonight. And as you're developing, and I may have mentioned this before, especially when you're developing inside of mommy as a fetus, right? When you were just a couple layers of cells, those outer layer cells migrated and pushed inwards inside towards the center of your body, but they didn't go far. They only went down into the dermis, right? So essentially you'll have tissue that used to be, or at one point was part of the epidermis, but now resides in the dermis there. And so we call these the epidermal derivatives there. And so keep in mind, they came from the epidermis, but they now live in the dermis. It's like me. I'm from New York. That's where I came from. But I live here in South Carolina. All right. That's where I live now. Right. So I came from a different place. Right. So that's kind of it's not the best analogy, but you get the point. So again, nails aren't terribly exciting structures, but I'm going to go through a couple things with you when we're talking about the nails. And so I'm going to be doing a lot of back and forth. And what I mean by that is I'm going to be flipping from this slide to an actual picture of a nail. But one of my favorite items that you will learn here from nails is they actually come from the stratum corneum. Right? And so your nails essentially will come from the outermost layer of your epidermis. And so, but obviously, your nails are a lot more rigid and stiff. So there are some modifications that took place, right, for that tissue there. And so we have nails on the distal parts of our fingertips, what we call the dorsal or posterior side. And then you also have nails on the ends of your toes, all right? So the distal portions of your extremities, like the very distal portions there. And so, of course, our nails are there to help protect us. And I'm sure there's been many times when you've been grateful to have a nail that when you drop something on your finger or on your toe, that if you didn't have that nail there, it would probably hurt a lot more. So big function of nails is protection, right? Obviously, we've seen in the animal kingdom that they've used their nails, all right, when they're in combat. And then also we'll see another part with the nails, and we've all done this, it helps us to pick things up, right? So it allows us to help grasp things. So you got your fingerprints, right? We have those epidermal ridges there that help to increase friction and make it easier to grasp things. Well, our nails will help us with grasping things too and helping to pick up things. So a couple different vocab words that you'll need to know when we're talking about our nails. So the first one that you see up there is the free edge. That's the part that you cut off when you're cutting your nails, right? So the free edge is going to look like this. Here in this picture, you can see there's the free edge. That's that white part there that you essentially clip off when you're trimming your nails. Easy, easy. Right? And so underneath that now, under your nail, you'll see that you have this area called the nail body. And it's going to have this pink appearance because of all the capillaries there. So you see the free edge is the white part. And then the other part of your nail that has that kind of pinkish hue, that's going to be the nail body. And it gets that color because of all the capillaries there. So here you can see, here's the nail body. So it's pretty much the remaining part of the nail that is exposed. So the nail body is this whole area here. And so where it is lighter, I shouldn't say a lighter color, but where it is here, that is going to have more of a pinkish type of appearance because of all of the capillaries underneath. So we learned in lab when we were talking about hair, your hair has a couple different parts to it. The part that's underneath the skin is called the hair root. And then the part that's above the skin that we can see on our bodies is the hair shaft. Similar situation here with the nail. Okay, the part that you can't see that's underneath your skin, that's the nail root. All right, and so those three parts, the free edge, the nail body, and the nail root, all three of those make up what we call the nail plate. I don't know if anyone here has ever had the pleasure, and I'm saying that with a lot of sarcasm, of losing a nail, right? And so it happened to a roommate of mine in college. He banged his foot real bad. We tried to alleviate it. He got blood trapped underneath his nail. I heated up it was a needle. And it's amazing. If you heat a needle hot enough, it will go right through the nail plate like butter. And so I learned this in a sports medicine class, stuck the needle into his toe, and the blood came out. We relieved it, but we lost the nail. It still had to come out. Well, anyways, when he lost his nail, that was the nail plate, the whole thing, the free edge, right, the nail body, and then the actual nail root. That whole part is considered the nail plate. So that's what we're seeing. Let's get rid of this. That's what we're seeing here at the bottom there. Right? The nail plate is this whole structure that's embedded on the distal part of, in this case, a finger. All right, and then underneath the nail is going to be the nail bed. And that's the epidermis, that the skin there that sits underneath the actual nail plate. And so that is what we refer to as the nail bed. So you'll see that here. There's the nail bed. And you can see it's kind of highlighted with a pinkish type of color there for the epidermis. And that's, you can see it all around the actual distal end of that finger there. Okay, not too bad, right? Not too bad. All right, a couple other things here. Nail matrix, lanula, nail folds, all right, the cuticle or the epiconium, and then the hypoconium there. So the matrix, and again, there's some similarities between hair and nails, and we learned some of those similarities in lab, right? The nail matrix, actually, we didn't learn about this in lab. The nail matrix is the part of the nail that is growing, because as we all know, right, when our nail grows, it grows out from our finger. Right, so essentially from your last knuckle out to the tip of your finger, it's just pushing the nail out. And it's the matrix which actually has all of those cells that are constantly dividing, right? That's the growing part that are going to just push your nail out distally there. And for those of you that have gone in and had manicure or pedicure, right? So when they've mentioned things about your cuticles, they're referring here to the lanula here, or not the I'm sorry, they're referring to the epiconium. Oh my gosh, what happened there? All right, so the cuticle is that bit of skin, and you can see it on your own nails, that overhangs from your skin onto your nail. So that's this part here. This little, I'm afraid to draw it, but that little bit of skin here. There, actually, let me zoom in. There it is, this little ridge of skin here. That's the cuticle, also known as the epiconium there. But you'll notice right here, there's a lighter area called the lanula. And I think of lunar, moon, because it always reminded me of one of the phases of the moon there. Can't remember all the different phases of the moon. But the lanula is that lighter, whiter area there. And the only reason why it doesn't appear pinkish is because it's thicker. The skin underneath that part of the nail is thicker, so you can't see the capillaries, or the blood underneath the capillaries won't show through. So that's why that area looks white, right? Only because it's thicker in the lanula. right? And then on either side, the lateral parts of your nail, you have what's known as the nail folds. And so that's going to be this area here. Here's one nail fold. Here's the other nail fold. Well, kind of where the skin kind of folds underneath the actual nail body. And then finally, you have what's known as the hypoconium, and that's pretty much where that free edge there of your nail hangs over the distal part of your skin. Some of you may have seen this because you may have cut your nails too short, and you'll kind of feel like a little bit of a thickened ridge area of skin there, and that's the hypoconium. That's this area down here. So if I zoom in a little bit, pretty much where the free edge right here, where it hangs over, right, the distal part of your finger, right here, it's the thickened area of skin, that's called the hypoconium. All right, so that's pretty much it for the nails. Nothing terribly exciting, but kind of, you'll probably see 1 or 2 questions on that in your test. Okay, so first clinical view of the day, right? And some of you might be like, hey, you know, I've always wondered about some of these things. The first one are brittle nails. Anytime that you have, right, it could be a result of inefficient nutrition, anytime you deplete nutrients from your body, you're going to see, right, signs and symptoms show up somewhere. And so in certain cases, right, when you have brittle nails, you'll see the nail itself will start to get these tears right down the middle here. It's because the nail body, the nail plate has become so weak that the nail will, I won't say will fall apart, but we'll start to see the layers here of the nail plate, right, start to separate and things start to crumble away. Ingrown nails, that's a tough one. All right. I don't know if anyone here has ever had an ingrown nail. They can be very, very painful. And that's essentially where parts of the free edge of your nail plate can start to dig in to the skin. You'll normally see it mostly in the feet, right? Not so much in the fingers. And again, ingrown nails can be attributed to several things. Ill-fitting footwear is usually what causes ingrown nails there. And sometimes if people suffer some sort of damage to the foot there and the toe, all right, that too can cause an ingrown nail. All right, fungal infections, that's onychomycosis. That's a real pain in the rear end because you don't get a lot of blood flow there, and it can take anywhere, folks that have onychomycosis, a fungal infection of their toenails especially, you can be on medication anywhere from 6 to 12 months. That's how long it takes to actually get rid of that type of fungus down there. All right, yellow nail syndrome, you will see this in the older population, right? And why? Because I said before, as we get older, everything in our body starts to slow down. And so your nail growth will start to slow down. And that phenomenon will cause a yellowing of your nails. And you can see that, look in your geriatric population, for those of you that are in patient care, right? Most everybody here is pretty much of young age, really won't compare your nail color to a geriatric patient's nail color. It's not, no, it's not. It's just, you'll see it more often in that population just because of the slowing. All right, spoon nails here, literally the nail itself will become concave. So it'll kind of look like this if you're looking at the nail straight on, right? So it'll just seem like it's more curved. Right, those spoon nails, Bowes lines here, a lot of you might even have it. If you look, sometimes you'll see these white lines that go across your nails there, and those are the bow lines. And it could be from most of the, someone told me a long time ago, and I haven't seen anything to substantiate that it was from a vitamin C deficiency. I don't know if anyone's ever heard that. You heard that? Okay. Again, I haven't seen any literature. All right, good. I'm glad I'm not the only one. But most of the time it's from trauma, right? So if you strike your fingernail against something, it can temporarily slow down the growth there. And so that's a Bowes line. And then vertical ridging, I can guarantee you that probably about 25% of the people in this room has vertical ridging. Again, looking down the tip of your finger, you can see how there's these small ridge lines there. And again, doesn't mean anything. It's just how that nail plate is growing there. right? So keep that in mind. Vertical ridging, pretty much nothing wrong with that. Okay, let's move on to hair. We're going to learn about the different types of hair. We're going to learn about the purpose of hair, the function of hair, all that fun stuff. So when we're thinking of hair, you should be thinking locations. Where is hair found in the body? Well, obviously, most of us know on the top of our head, eyebrows, eyelashes, arms, legs, right? When you get to puberty, you're going to get a growth in your pubic areas and in your axilla there, right? The armpits. So again, we're going to see hair in various locations all over the place. But when we're looking at our hair, and you've probably seen this when you were reading through the chapter, when we're talking about a single hair, we refer to it as a pilus, right? And it's pretty much made up of keratinized epithelium. So those cells are dead. They produce protein, keratin, to actually strengthen the actual hair itself. So similar situation that we saw with the epidermis, right? The epidermis, the keratinocytes are going to be, reproducing, growing, making relationships, interlocking with one another, and then eventually producing that keratin and then killing themselves, but in doing so, they make themselves stronger. Similar here with your hair, same type of thing. Those cells are going to keratinocyze themselves, and at the same time, they make the cell stronger, but they actually end up killing the cell. So, 3 types of hair that you are going to find: lanugo, vellus, and terminal hair. The only time that you're going to see the first one listed up there, the lanugo, right, which is that unpigmented and really no color, really soft, downy hair, right, is going to be right in a 3rd trimester baby, and you'll even see it on some babies when they're born. Okay, they'll have, some people describe it as peach fuzz, but you'll see an excessive amount. That's the only time you'll see this in an individual's life, except one other time, and that's under a pathological condition, right, in which you'll have an individual that has anorexia nervosa. For whatever reason, I cannot tell you why, folks with anorexia nervosa, all right, will produce lanugo hair. The next one is the vellus. That's the fine hair. This is the hair that you're going to see on your arms and on your legs, right? Pretty much all over the place. And then finally, we have our terminal hair. This is the colored hair that's going to be a little bit thicker than the vellus hair. And so this is the one that you're going to see on your head, right? Your eyebrows, your eyelashes, and for males, it's going to be in our beards. And so a lot of times, right, you won't see, because remember what I said, sebaceous glands are associated with hair, right? So some of those sebaceous glands won't be activated until puberty, right? But also during puberty, we are going to see a lot of that vellus hair, right, that was in your armpits and the axillary region and the pubic regions, right? That vellus hair will be replaced with our terminal hair. So it'll become thicker, more pigmented, right? Again, all has to do with hormones, which you'll learn about when you get into chapter 17. So those are our 3 types of hairs. Keep in mind that all hair comes from the hair follicles. Okay? Hair follicles are associated with the hair. All right, so when we're looking here at a single pilus, one single hair, there's 3 parts to it: the hair bulb, the root, and the shaft. We talked about 2 of those. Well, we talked about all 3 of those in lab. Okay, the shaft is the part that is going to be above the surface of the skin. The root is going to be below the surface of the skin. And then the hair bulb is going to be basically, I'll try to draw a picture. There's the bulb. Here's the hair root. Here's the surface of the skin. And then our hair shaft up top. All right, so the hair bulb is where your hair is growing from. And that's going to be down in the dermis. The hair root will travel up through the dermis, up through the epithelium, through the epidermis. And then once it's gone out of the epidermis, then we refer to as the hair shaft. All right. Also in the hair bulb, all the cells are living. Okay, so those keratinocytes haven't killed themselves off yet. They're dividing in the hair bulb, right? But they haven't fully produced that keratin to kill the cell off. So as the hair cells are making their way, they start down here in the hair bulb, and they migrate upwards towards the surface of the skin. Then they'll start producing the keratin, then they'll start to kill themselves off there. So I'm going to, again, for this next slide, I'm going to go back and forth between this slide here and this slide here. So a couple of the components of our hair matrix, the medulla, the cortex, and the cuticle. I want you to know right now, you're going to be hearing terms like medulla and cortex. So for right now, when you think of medulla, think middle. And then when you see cortex, think outer covering, outer surface, whatever. Okay, so the medulla is usually in the center because we'll see that in the kidney, we'll see that in the adrenal glands, some other structures. Right, so the medulla is more in the middle, the cortex is usually on the outside, like a hard-boiled egg. You got the shell on the outside, that's the cortex, and then on the inside you have the egg, that's going to be the medulla. All right, so the hair matrix is located in the hair bulb. This is the area where all the partying's going on. We're just having a big party of cell division. So that's all that's going on there. So cells are dividing, and then the older cells get pushed towards the surface of your skin. So all of those cells in the hair matrix are living. A, because they're dividing, and B, because they haven't been producing any keratin yet to kill themselves. So in the matrix, I'll show you a picture. Here you can see way down, here's the hair bulb. And then you can see you have your hair papilla, which is where all the blood vessels come in. And then all of these cells here are in the hair matrix. You can see it a little bit better here in our stained slide here. So these are all blood vessels that are coming in and leaving. And then here is the matrix. You can see it over here also. All of these cells in this region are rapidly dividing, and then the older cells are getting pushed upwards. So the next part is going to be the medulla, and so the medulla is in the middle here. So you can kind of see it. It's represented by this brown streak here at the center of our hair, or the pilus there. So that's the medulla. So you can see it here in the middle. And then what surrounds the medulla is going to be the cortex, and that's colored here by this tan coloration there. So a couple things about that, right? So the medulla is going to be where those living cells are going to be pushed forward. So it's a remnant of the matrix. But again, we're starting to produce that keratin. And so those cells are still soft and flexible, which is important because they haven't hardened completely yet. Right, and so the cells in the middle are soft and flexible, and then the cells on the outside that surround the medulla, okay, those are going to be the ones that are going to be hard, which gives our hair its kind of structural support. The rigidity of your hair, right, is due to the cortex there and not to the medulla. Cortex is on the outside. So that's what we're seeing here. The tan part, that's the cortex. The brown part in the center, that's the medulla there. And then on the outer surface of the hair, okay, surrounding the cortex, that's your cuticle. It's nice that they used a term that they already used to describe your nails, but we'll use it again, right? The cuticle is just one cell layer thick that surrounds the cortex there. So it looks like that. It would be that, I don't know what color that is, black or brown, that dark black or brown line that you can see that's surrounding the tan area there. That's the cuticle. All right, any questions so far? I know it's not the most exciting stuff. Just bear with me. All right, just bear with me. We'll get to some interesting stuff here. And then finally, the last two parts when we're dealing with hair are going to be the hair follicle. And like I said, the hair follicle, think of the hair follicle like a sleeve on a long sleeve shirt. Some of you are wearing sweatshirts or whatever. That's the sleeve, and your arm is going to be the hair. That's the hair follicle relationship to the hair itself. Right? So it's essentially a tube that surrounds the hair root, and it is going to travel with the hair through any of the layers that the hair, so it's going to go through the dermis, going through the epidermis there, okay? And sometimes, depending on how deep the hair is, it can be even in the hypodermis or the subcutaneous layer here. So one of the interesting facts when we're talking about the hair follicle, right, is that you have two parts to it, an outer part and an inner part, right? The outer, what we call connective tissue root sheath, that came from the dermis, right? And then our inner portion, that came from the epidermis. That's the epithelial tissue root sheath. So the inner part came from the epidermis, the outer part came from the dermis, which makes sense, right? Because think about it. What did we say? These are epidermal derivatives. So imagine my fist is that epidermal derivative that's starting to push down into the dermis, and it pushes in, and the dermis covers the epidermis there. So the inner portion is going to be that epidermis that invaginated from that top layer of tissue during fetal development. And then the outer layer that's covering is the dermis because it moved into the dermal layer there. And then what attaches onto our hair follicle is one of our other tissue types, our muscle cells. All right, and so the smooth muscle, that means it is, what are some of the qualities of smooth muscle that we've learned so far? It's involuntary, that's right, you can't control it. There's no striations, right? Because, yeah, so that means we don't have sarcomeres there, and we'll learn what those are, right? So it's involuntary, so we can't control it. No striations, single nucleus, right? But it's these muscles here, when they're stimulated by the sympathetic nervous system, your fight or flight part of your nervous system, that's going to give you goosebumps. And so essentially what happens, you'll see, all right, on the surface of your skin here, you'll get a little bump from that smooth muscle cell pulling on the hair follicle, and it kind of causes the hair to take this kind of position there. Part of it is from the sympathetic reaction, but also part of that, when else do you get goosebumps? When you're cold, yeah. And so the reason why is this phenomenon helps to trap heat. Your hair will literally try to help to trap heat close to the surface of your skin. Go ahead. All right, I'll tell you now, because we're going to learn that later on in the semester, but that's a perfect question to ask now. That's part of the sympathetic nervous system. What you're doing is you're experiencing, all right, part of your brain has this, not region, but these components that are called the limbic system, the emotional brain. So when you experience emotions, that will then trigger, well, it could possibly trigger the autonomic nervous system and the sympathetic nervous system, which will trigger those goosebumps there. Yeah, so there's an emotional component to it. Yeah, so you say you're watching something cringy, yeah, you'll get that. Okay. So some of the functions of hair, and a lot of us, when I go through these, you're going to be like, yeah, I knew that. And it makes sense. One, protection. Okay. Especially for more light-skinned individuals. All right. You've seen it with bald individuals, mainly men. They have to wear a hat when they go outside or go to the beach. All right. Because the hair is not there, so they cannot get protection from the sunlight. All right. Same thing with injury. There's been times I know that I would have scraped my head if I'm walking under something, if I didn't have hair there to help, all right, protect me. I mean, it's not going to give me a lot of protection, but I've walked under a branch or two, and if I didn't have hair there, I would have scraped my skin. So it helps with protect from injury there. We'll learn as we get into some of the other systems, specifically the respiratory system. You have hair in your nose, okay, called vibrissae. And that hair helps to filter out particulates that you might breathe in, especially around this time of year and in the spring. There's a lot of pollen, right? And certain allergens that are floating around. And so hair will help depending on which systems you're talking about. Okay. Hair in your ears helps to keep particulate matter from getting into your ears. Hair in your nose helps to keep it from getting into your respiratory system. Heat retention makes sense. All right. I would always let my hair grow longer in the wintertime when I lived up in New York to keep my head warm. Right. Obviously, being down here in South Carolina, it doesn't get as cold, so I can keep my hair shorter. So hair can offer heat retention. Okay. Folks that do have more hair, I hate to say it, but certain individuals, right, might have hair on their back. Right. And again, it helps to keep them warm. And some of those individuals, maybe somewhere in their ancestry line, lived in a cold weather environment, and they needed that hair at one point in their lives to keep warm. Sensory reception. How many times have you been outside? You could be laying on a blanket and a breeze blows by you with your eyes closed, and you can feel that breeze because it's moving some of your hair on your limbs, on your head, right? And on some of your hair follicles, you'll have sensory receptors that monitor the movement. So if the hair moves because the wind is blowing, it'll cause the hair to move in the hair follicle, and those receptors will sense that hair movement and then will send sensory information to the control center saying, hey, there's something happening here, right? That light touch kind of phenomenon going on. Now, most of us have seen this when you're meeting an individual, right? Compared a small child to someone that's 85 years old, you'll notice the color of their hair can help determine their age. Right? And so when we talk about visual identification, older individuals will usually have white or gray hair. Younger individuals will usually have full working, functioning melanin production going on in their melanocytes. And so their hair will look a specific color to whatever their melanin predisposition is. Facial expression. I can't tell you how helpful that was for me during COVID. I don't know if some of you were taking classes when we had to wear masks all the time. And as a teacher, it's very difficult, right, for me to tell if somebody is confused on material when I can only see this part of their face, right? So I had to rely a lot on what their eyebrows were doing. If they were thinking, or if they were like, I don't really quite understand that, and they're kind of squinting, right? It helps facial expression, right, with eyebrows specifically, right? I found to be very helpful during certain times while I was teaching. Chemical signal dispersal, pheromones. Pheromones are the scent that you as an individual create. All right. And then what will happen is that scent will be excreted through your exocrine glands, i.e. sweat glands, onto your hair, and then it'll be dispersed into the air. Okay. So essentially, whatever your scent is, whether it's pleasant or unpleasant, all right, your pheromones, it will then, all right, be dispersed onto the hair. And then that's one of the ways that you can smell people, I guess is the best way for me to say that. All right, hair color. What makes our hair color what it is? Melanin. Right, and so melanin that is being produced as your cells are growing, the keratinocytes, right, that melanin gets deposited into those cells there. And then as you get older, like I said, things start to slow down and decrease. And so as we age, so does your melanin production. So if you see an individual with gray hair, then they're still making melanin, but it's just less. Folks with white hair are not making melanin. Okay, they're a quitter. Go ahead. Yes, that's a great question. Yeah. Yes, a true ginger, true redhead, all right, will not have gray hair. All right, they will have white hair. So usually if I have a beard, about most of my beard is white right now. And I never had gray hair. I went strictly from red to white. And it's just whatever it is. For gingers, they just stop producing melanin. Yep, so I'm a quitter. Yep, yep. I'm not happy about it, but that's how it is. All right, so your hair, grows roughly, I mean, it's not a huge number, but 1/3 of a millimeter a day. Right. And so this will happen on the terminal hair for your scalp. So anywhere from 2 to 5 years, that's the going rate. Now, some people's are more, some people's are less, depending on. And I'm sure for any of you that have ever been pregnant, you probably noticed that your nails were growing more, all right, and your hair was growing more. And that's because a lot of changes occur in the body during pregnancy, all right? So the rate of hair growth on average is about 1/3 of a millimeter a day, all right? Go ahead. You know, that's a great question because I know plenty of people. Correct. Yes. Certain areas there, scalp hair, it'll definitely slow down. And I know that there's certain cultures. I went to medical school with a girl. She was Sikh. And in that faith, in that culture, men aren't allowed to shave their beards or cut their hair. Women aren't allowed to cut their hair. And this girl had never cut her hair. And she wasn't very tall. She was about, I'm not saying that 5'2" is not tall, all right, or short. But my point being is her hair, all right, it was so long, she had to braid it. And then I don't know what the term would be, but she had to bring the hair back up because she wasn't tall enough to keep her hair from dragging on the ground. All right. And she was in her mid-20s. And so I asked her once, I said, does your hair ever dry? She goes, it never dries. You know, it never dries because she braids it and whatnot. But point being is it slows down. So for the scalp hair, and like what you were saying about the eyebrows, yes, because otherwise our eyebrows, would just keep going. All right. And we'd have to go to the barber and get those cut. Right. So there is in certain areas, yes, it will stop. All right, or it'll come to a crawl in growth. But scalp, again, that varies. It will still grow, all right, because again, if you go by this, it says, oh, the hair will go dormant for 3 to 4 months after that 2 to 5 years. No, it still grows. It still grows. All right, it can go dormant here but what will happen in most cases, right? The hair gets damaged and then it usually just falls out. I live with people in my house that for whatever reason, when I get into the shower afterwards, I hope to catch them on a good day because there's not hair on the wall. You all know what I'm talking about. I know, all right, or most of you know what I'm talking about. All right. Some people, all right, if they're washing their hair, it'll get on their hands and they put it on the wall and then they're like, I'll get that later on. All right. And they don't. And it drives me crazy. All right. So hair growth, real quick, 3 phases: anagen, catagen, and telogen. Anagen is going to be the active phase. Right? The catagen, we see a slight brief regression, and then the telogen is the resting phase. I just want you to know those. There's nothing really exciting about any of that, but there you have it. All right? Anagen, catagen, and then telogen. Okay. Hair loss. This is an interesting stat. All right, 10 to 100 hairs per day. It's not absolute. Okay, could be less, could be more. Right, but for the most part, individuals that get thinning of hair, that is going to be called alopecia. Now, most of the time, it's due to aging. Not all the time. Okay, if you're getting alopecia in a young individual that's in their 20s, all right, you should start to think a couple of things. Most of the time, it's going to be exposure to something or some of the drugs that they're taking. Right, there can be a hormonal component also. Right, but you got to just start running through that. If it's a young individual that's getting alopecia, right, then there's something causing that. Right, age-related alopecia, again, it varies. More common in men to lose their hair at an earlier age. Right, women, you won't see it as much. Right, so when we see the diffuse hair loss, this occurs, right, mostly in women. But again, what is causing it? All right, if it's age-related, it could be hormone production starts to decrease over time. So you might start to see gradual hair loss, diffuse hair loss in females, right, because hormone production decreases. But if they are young, then that's when you should start to think there's another cause. Most of the time, it's usually due to drugs. All right, I'm not saying illegal drugs. Maybe they're just getting some prescribed drugs, and that's one of the side effects. Right, and so iron deficiency is another. Right, and so again, iron is used obviously to help make hemoglobin effective, but we use iron for other processes in the body, right? And so you can see iron deficiency causing diffuse hair loss. All right, male pattern baldness, we're all pretty much familiar with this, I would think. Usually they'll retain some of the hair on the sides of their head, but on the crown, which is the top, they'll usually lose hair there. And so that's when we talk about male pattern baldness, that's usually the appearance of most people. Most of the time, it's going to be genetic, right? And so from what I've heard, it comes from the mother's side of the family, right? But also, right, there could be some hormone interaction there. Folks that take steroids, okay, metabolic or anabolic steroids. That's one of the side effects of metabolic steroids is male pattern baldness. And if you see that male pattern baldness in somebody that's relatively young and they've got a pretty big frame, all right, there's a good possibility that that could be from steroids. And in this condition here, hirsutism, and that's excessive male pattern hairiness. Hirsutism you'll see in females, and in some cases, women that have polycystic ovarian conditions, they have a higher incidence rate of hirsutism. What we use to help treat that is just put them on birth control, help regulate, okay, the hormone levels there, and you can deal with the hirsutism. I actually knew somebody that had this, and she treated her hirsutism with birth control pills. All right, let's leave hair and get into our exocrine glands here. And so this right here, some of these slides are going to be a little bit of a review of what we talked about in lab. So we get to kind of relax our brains here for a few moments. And I just want to review, right, because in later, well, not later chapters, but in 211, we'll kind of revisit these glands here. So I just want you to have a pretty decent understanding and baseline here. All right, so when we talk about our exocrine glands, we have two types, sweat glands and sebaceous glands. And in our sweat glands, we have two subtypes, merocrine and apocrine glands. And so essentially, when we look at a lot of these glands, what happened is these glands are what we call, if you recall, in lab, we have tubular glands. This is killing me, which is just a big, long tube. And what we're going to do is we're going to roll that tube up and coil it up into a ball. So when we look at these sweat glands, they'll have this coiled appearance, but keep in mind, it's just one long tube that we just rolled up. And so the secretory portion, because remember, there's two parts. You've got the secretory portion, which makes the secretions, and then you've got the conducting portion, which is going to then move those secretions from the gland onto the surface of the epithelium to which whatever they're excreting it onto, right? Mainly the skin, since we're talking about skin, right? So you have these specialized cells, myoepithelial cells. Myo, think muscle. So these special cells will act like muscle cells, meaning they'll contract and relax. And so their contraction will literally push the secretions from the secretory area or portion of the gland into the conducting portion there. So it helps to aid moving the secretions out from the gland onto the surface of whatever that gland is secreting stuff. So these myoepithelial cells are these special types of cells there that help with that. All right, so here you have the gland, and then you've got the duct, and then you've got the surface to which that gland is going to secrete its secretions. So when we're looking at the skin, right, and I'll show you this, you've got the sweat gland duct right here, and then if you're looking at the surface of the skin, you'll see this hole here. And that's the sweat pore. You can actually see on some individuals, you can see it on your skin. It's a very small structure, but you can see the sweat pore there on some individuals. Okay, I already talked about that. All right, let's talk about the first gland here, the merocrine glands. So these are the ones that are responsible when you step outside, right, from this nice cool room in the beginning of the semester when it was still like 95 degrees outside. When you step out of the nice cool environment, you get into your car and you start to sweat and pour sweat. These are the glands that are responsible for that. All right, so they are going to be the most numerous that you'll see in the body. And so these are the glands I was telling you about, where the cells make their secretions through and get rid of those secretions through exocytosis. Exocytosis is that process where we package up something inside of a cell and then we ship it to the plasma membrane and it gets released from the cell. It requires energy, okay? So it's an active transport process. So exocytosis is how these cells manage to move their secretions from inside the cell to outside the cell. Interesting fact that most of the secretion for these cells is water. The remaining 1% are either going to be electrolytes, metabolites, and then waste products. Okay, so metabolites like, hey, my sweat is salty. So some of those electrolytes would be sodium chloride, okay? Maybe some potassium, some magnesium, all of that fun stuff. Those will be your electrolytes. Metabolites are going to be some of those material structures that you'll have with our chemical processes for the chemical reactions. And then the waste products at the end, right? Like cells, like us, you know, we eat food, we digest it, we excrete it. Our cells do the same thing with nutrients, right? They ingest it, they ingest it, digest it, and then excrete it. And that waste product, like urea, for example, or some ammonium compound, right? Well, all of these will be found in the Merocrine sweat glands here. They play a huge role. We learned about this back in chapter 1, all right, of cooling our body. You get too hot, you start to sweat, and that's as that sweat evaporates off, it gives that cooling effect there. Right? And so that is a part of our thermal regulation, that whole negative feedback. Well, you just actually, one of the essay questions on the test talked about that, right? That negative feedback loop there. All right. Merocrine sweat glands, again, help us with water loss. Very small percent of our water is lost through sweat, right? But also our sweat will help with dilution of chemicals. And then also that sweat, when it coats our skin, will actually, believe it or not, help make it a hostile environment on the surface of your skin. So it makes it tougher for certain microorganisms to exist there. So it actually contributes to a certain antimicrobial effect on the skin. Sebaceous glands do it very, very well, right? But the Merocrine glands do aid in that. All right, the next type of gland are the apocrine glands. Again, long tubular gland that we rolled up into a ball. These glands, though, okay, are associated with hair follicles. So they are going to be located in places where there's hair follicles. So axilla, right, areas around the nipples, and then our pubic and anal regions, right? So these areas, all right, you don't get hair in some of these areas until you hit puberty. Well, guess what? These glands don't become active until you hit puberty. So these glands, when they're making their secretions, they're going to make it through the same process as the Merocrine glands. They're going to make it through exocytosis. Right? And this is the one I was telling you about, where these cells blow their tops off, or the apical region or apical plasma membrane. So they'll make their secretions through exocytosis, but instead of just having the normal exocytosis process happen, right, these cells just get rid of their secretions by blowing the top off the cell. And so because they do that, our plasma membranes have that phospholipid bilayer. So what's in that phospholipid bilayer? Proteins and lipids. Now, we like to eat things that have proteins and lipids in it. Well, guess what? Other things that live on our skin like to do the same thing. And this is one of the reasons why people will have a certain funk to them, excuse my language, all right? If you have a teenage son, like I do, he'll stink, all right? And part of that is because these glands become active in puberty. They start producing their secretions. Those secretions are rich in proteins and lipids, and certain bacteria love proteins and lipids. So they'll start to migrate to these areas and start gobbling up those proteins and lipids that are on the hair and on the epithelium there. And what do some of these bacteria do? Like we do? They poop. All right. So they create waste, and their waste, like ours, stinks. All right. And so that's what can cause certain people say BO, body odor. All right. This is one of the phenomena that can contribute to that body odor, is that bacteria, okay, will actually feast on those proteins and lipids and then create their waste. Yeah, they should. Yeah. So again, this doesn't happen. These glands aren't active until puberty. All right, then our other type of gland, the third type of gland, is going to be the sebaceous glands. And these are those glands, right, that are known as holocrine glands. And so their secretion, we call it sebum. So if you've ever laid down somewhere where there's some paper and gotten off that and you see like this oily discharge onto the paper, a lot of that is sebum, which is a good thing. It's not a bad thing because look, sebum lubricates. We all could use that. That's helpful. It is bactericidal, always helpful. Let's kill some of those bacteria organisms that live on our surface of our skin there. So sebum is a good thing. And so I always tell patients, you know, if you have oily skin, now there's access to that, but in general, if they're laying down and they get off my table and they have some oil on the paper, I said, that's a good thing. People always point that out. So these glands become active also during puberty. And so what stimulates their production is going to be a hormonal situation. So certain hormones, right, are going to stimulate the activity of these glands, specifically androgens. Does anyone know what an androgen is? Androgens are male sex hormones. So in females, in y'all, right, you'll produce androgens, but your bodies will convert those androgens into the female sex hormones, okay, like progesterone, estrogen, right? So you're producing androgens, but you're just going to take an extra step and convert those over. Point being is these hormones will affect the activity of these sebaceous glands. So obviously, if you think about it, when you're in puberty, those hormone levels increase. So do the activities of these glands here. Just look at any teenage kid, right? They usually will have an oily face, not always, but they'll have more of an oily face. Golly. Okay. Some other integumentary glands, right, are ceruminous glands. Those are the glands that live, all right, in your ear canal. And so they're going to produce cerumen. Earwax. It is waterproof. Okay, it helps, all right, to repel water, and it also helps to trap material that gets in your ear. When I was living down in the Caribbean for a few years, I had a roommate there that refused to clean his ears. And he said the reason why is because he didn't want any of the bugs that were native to the island to crawl into his ears. Because we heard, again, you hear stories, and he heard stories of bugs crawling into people's ears and whatnot. So he was bound and determined not to have that happen. So he didn't clean his ears out all 3 years that I lived with him, right? To each their own, okay? But that cerumen there, right, will help to trap those foreign particles, and it also acts as lubrication. And then our mammary glands, right, those are modified apocrine glands there. And so those are the glands that are going to produce, all right, breast milk. And so during pregnancy, during nursing, right, a lot of the tissue, a lot of the cells in these glands will proliferate, okay, become more numerous so we can produce more breast milk to feed baby. All right. So that brings us to our next clinical view, acne, okay? Acne. Most of us have experienced acne on various severities, some pretty mild, some pretty severe, okay? But acne has to do with our sebaceous glands. So therefore, acne really doesn't become a consideration until an individual gets into puberty there. So what will happen is when the glands are starting to become active and they're producing their sebum, right? They increase their activity, they make themselves more prone to getting clogged. When they get clogged, they get blocked. When they get blocked, then you can trap in that foreign material and bacteria. And so what you can have happen is you can get, I don't want to say infections, but irritation to the pore there and or to the hair follicle and whatnot. And so certain ways to treat that, okay? Things that have benzoyl peroxide, like I don't even know if they make so Oxy-10. I don't know if that's still a product that's out there. When I was younger, it was Oxy-10 and Clearasil were the two big products to use for acne. And so both of those products contain benzoyl peroxide and the salicylic acid there. But if it gets pretty bad, you can prescribe antibiotics. And a lot of what we're seeing now is this retinol, this vitamin A compound there that helps with reducing acne there. Okay. If it's pretty bad, if you don't do anything about it, it can lead to scarring. All right, we're winding down. We're getting close to the end of the chapter. And I'm really glad that I get a chance to talk to you about some of the things that we're going to be discussing here, because when you get into 211, you're going to learn about what happens when you get like a cut on your skin and some of the processes that are involved. This is going to give us a broad overview, and then you'll get into more detail later on in 211 here. All right, so when we're talking about tissues and tissue repair, we're going to see that tissue repair can happen one of two ways. For me, there's a preferred way and there's the non-preferred way. The preferred way is regeneration. Damage the skin, right? And then what happens is whatever was damaged, we replace those cells, right, with the same type of cell type, right? So if I damage some keratinocytes, I replace those dead or damaged keratinocytes with healthy living keratinocytes. And the nice thing about regeneration is we restore function. Okay, that's the good one. Regeneration is good. We like regeneration. Then there's fibrosis. This is the one that we often hear people talking about, scar tissue formation. So now you've damaged the skin, and instead of getting replacements of healthy new cells of the same cell type, we get our fibroblasts shooting out tons of collagen. Remember collagen? That's the protein fibers there. And so collagen gets ejected into the damaged site of the tissue there. And instead of getting healthy cells in there, you get collagen. And so now instead of having those functional cells there, now we just get scar tissue. And so we pretty much say goodbye to function. So you might notice in some scar tissue initially, you might not have very good sensation there because we've lost the sensory tissue that was once there. And we've replaced it with collagen. So regeneration and fibrosis, those are the two ways that you can get healing to occur, right, in our skin. So let's talk about that. Let's talk about wound healing. So there's 4 stages that are going to occur in wound healing. So the first one there you can see is cut blood vessels bleed into the wound. What does that look like? That's what we see here. So you see, right, a knife, some sharp object has either punctured you or sliced you, and it's gone deep enough here down in the dermis, right, where it's cut some of these blood vessels, and the blood starts to seep and move into the wound here. That's the first phase. We're going to go through all 4. I'm going to go back and forth. All right. So the next part is we get a blood clot. Right? So the platelets and some of the proteins in your blood create this clot to stop the bleeding and to plug up the hole so things from the external environment can't get into our internal environment. There's a lot of bacteria, a lot of viruses out there that are just itching and dying to get inside to your body, right? So we need to create a barrier there. So the blood clot forms, and then we bring in our cleanup crew, our white blood cells, the leukocytes. So they're going to come on board, and they're going to start, if any bacteria or any pathogens manage to get into the skin there, they're going to start to initiate the immune response, right? And so mainly it's going to be neutrophils and macrophages. So those will come in, they'll start cleaning up the wound there, all right? And so again, the job here, right, is to make sure that we are protecting the body against any invasive pathogens. So that's the picture that you see here. Here's the second one, right? So here's our blood clot. So we start to form a scab, but we want to stop the bleeding. And then we get our neutrophils and our macrophages, and they're coming in and they're starting to clean up some of the damaged tissue. And if any pathogens manage to make it in here, they're going to go out and start hopefully killing those pathogens and initiating that immune response. So that's the second step. All right, so the third step is we damage blood vessels, so we got to fix those blood vessels, and we need to regrow the blood vessels. So some of the cells in the area start to produce these chemicals that stimulate that blood vessel regrowth there. And then we're going to start to form our early form of scar tissue, what we call granulation tissue. Right? Because if you glanced at this, if you glanced at this slide here when we were in phase 2 here, we saw macrophages, neutrophils, and guess what? Fibroblasts. Fibroblasts make collagen. So here in our third phase, we're repairing and fixing blood vessels and growing new ones. So again, we can supply these cells with the nutrients they need and the ingredients they need to fix the damaged tissue. And then our fibroblasts are in here laying down collagen that's going to create that granulation, that early scar tissue formation there. And then the last phase is going to be our epithelium regenerates and our connective tissue fibrosis is going to occur. What does that mean? Scar tissue. We're going to start to get, instead of that granulation tissue, scar tissue, which will be that more permanent tissue type that's going to replace the damaged tissue. Right? And that's kind of what you see here in this picture. You're seeing, all right, our epithelial tissue. You can see, all right, epithelial tissue was damaged here, and we're starting to repair it. And then our epithelial tissue, in phase 3 here, it starts to get closer and closer to the other epithelial tissue that you're seeing. And eventually that's what we're going to get. We get our epithelial tissue regeneration. We've regrown our blood vessels here. And then our fibroblasts have laid down that fibrotic scar tissue here. Again, that scar tissue, even though it's not as good as the original tissue because it's lost some of its functionality, it's still pretty strong. Right? It's still beneficial to have. All right, so those are the stages of wound healing. And I know it's not the most exciting stuff, but we'll go into more detail into 11. All right, psoriasis. All right, our next clinical view is psoriasis. Autoimmune disease. If you watch golf, you'll see tons of commercials for psoriasis. I don't know if it's because the population of people that watch golf suffer from psoriasis, but I always see commercials for it. I don't watch a lot of golf, but whenever I do, I see commercials for psoriasis. So a couple things. Autoimmune, which means it's your own body causing the problem. And that's literally what happens here. When we talk about autoimmune, it's going to be, right, some part of your immune system is going to attack another part of your body in another system somewhere. So literally the keratinocytes in your skin are going to be attacked by your own T lymphocytes, your T cells there. And then what will happen is when we attack those cells, well, your body wants to replace those cells. So it starts to grow new cells, more cells. So you literally start to get an overgrowth really fast. And so this overgrowth causes your skin to have this kind of scaly or whitish appearance to it. And so it's almost like the skin there is really dry. It's not kind of soft, all right? It's almost like a scab, right? It'll have that consistency of the scab, except it won't be like brownish reddish. It'll be more white, right? And so, of course, if you ever had a scab, it can be itchy, and that's what happens here. So these patients will complain of itching, all right, pain, cracking there. And so perfect solution to that, let's give them steroids, corticosteroids. Specific drugs I'm seeing a lot, I can't remember, is it, I can see it in my head. Dubry, I can't pronounce it correctly. But anyways, it's a specific cream that you can get, right, that will literally slow the production of collagen from your keratinocytes, and it slows down the reproduction of keratinocytes. So basically what they're trying to do is slow the growth, that rapid growth of those keratinocytes, right? So it doesn't produce that scaly whitish appearance there. And you can even use light therapy, ultraviolet radiation. Ooh, burns. Burns, burns, burns. Next clinical view here, right? So with our burns, right, one of the leading causes of accidental deaths, different types of burns. If you've ever taken like a CPR course or first aid course, they get into the different types: chemical burns, heat burns, all right, well, sunburns, all right. So there's different types. So the big thing when we're dealing with a patient, an individual that's had a burn, these two things here, fluid loss, infection, become the most critical components of patient care. One, you've got to keep that person hydrated. Now, if it's a sunburn, I don't think there's any risk of loss of life there, so you're not going to be too worried, right? But still, right, third-degree burns, different story. So the severity of the burn will dictate the treatment course. But you want to keep them hydrated, and you want to prevent infection. So let's go through the different degrees here of burns. There's 3 of them. So you have first-degree burns. So how I remember it is, if it's first degree, you're only going to affect one layer. So it's going to be the outer layer. So first-degree burns are only going to affect the epidermis. Okay, an example of this would be a sunburn. Okay, so you'll see some redness there and some pain. Second-degree burns, again, 2. So we're going to be dealing with 2 layers. So the first layer is always going to be the epidermis, and then only a part of the dermis here. So in these types of burns, right, this is if you poured scalding hot water on yourself, if you touched a hot pan or whatever, right, that those burns will produce some sort of blistering, again, pain and redness in the area there, and there's that possibility of scarring. The third type of burn are the third-degree burns. So 3, we're going to be involving 3 layers. The outermost layer, then the deeper 2 layers after that. So the epidermis, the dermis, and then the hypodermis, or the subcutaneous layer. These are the folks that are going to come into an urgent care facility or the hospital there. And again, like I said, we have to focus on dehydration and infection. And we're going to give these people a high-calorie diet. I don't work in the dietary. I used to work in a nursing home, and we had a dietary office there that was always paying attention to the clients' or patients' dietary needs. Well, here, right, third-degree burns, your body is, remember, you just damaged, depending on how much of the body was burnt, right, you just damaged the largest organ in your body. And so there a lot of regeneration and healing is going to occur. And so your body is going to need a lot of calories, all right, to do all that. All right, so in these folks, you will see quite a bit of scarring here. And depending on how bad the third-degree burns are, all right, you can do what we call, does anyone know what debridement is? Yeah. Yep. That's when they remove the damaged skin. So they're going to remove the damaged skin because it can interfere with the regrowth of skin. And then in some cases, we'll do skin grafts, right? Might have to move if your back was fine, but yet your calves got burned, you might have to take some skin from your back and put it onto the calves or whatever, right? So we use this philosophy called the rule of 9s. right? And so I don't think I have it on this. Yeah, I don't have it on this slide anymore, on this tissue, on this slideshow anymore. But basically, we divide your body up into 9 areas, and depending on how many of those areas have affected, will usually dictate the severity of the burns and the course of treatment there. All right, so again, I've already mentioned some of these here, but how do we treat for the burns? Dehydration is an issue, so we have to make sure that we keep the patient hydrated, right? Keep them comfortable, right? Make sure, right, that you are preventing any type of infection. So you want to make sure that we're using proper medicine or medication for that individual there, right? Control any of the pain and the swelling. And then, of course, we want to make sure that we're giving them an increased amount of calories, right, so they can recover and heal and repair, right, that damaged tissue there. Oh, okay. All right, last part. That way, if I go through this, I might run over a little bit, but then I don't have to send you guys a video. All right. So, and I never get to teach this part, so I'm glad I get to teach it with you guys. I can, but it's going to be on this video. It'll be on this one. Okay, so from here on out, when we talk about different systems, usually at the end of each of those chapters that we cover, we'll talk about the effects of aging on whatever that system is. So a couple things. When we're looking here at our skin, like I said, when we go through the aging process and as we get older, things slow down. Right? So I want you to keep that in mind. Right, so our skin is going to experience changes, right, just like the other systems will. So we're going to see the cells in our skin, and we'll talk about various types, all right, cells that, for example, that have to do with skin repair, which might be our fibroblasts, all right, and our macrophages there, right? What we'll see is we'll have fewer of these cells, okay, because we just don't produce them as much, right? And the activity of these cells decrease, right? So all in all, we see a reduction in the number of cells and the activity of these cells. So our skin takes longer, and it doesn't repair itself as well, I should say. Not to say that it's not doing the job correctly. It just doesn't do it as efficiently as it once did. Your skin starts to thin out, and some of you, again, if you've worked with the geriatric population, you might notice, like maybe grandma, she's wearing more Band-Aids on her hands and on her arms than that you're used to seeing from individuals. That's because her skin has gotten thin, and if she brushes up against something, she can scratch herself and damage her skin much easier there. And also, it takes longer for her to heal, right? So as we see it reduced number, and this is, I want you to really focus on this, reduced number and activity of stem cells. So if we have a reduced number and activity of these stem cells, cells that produce collagen, fibroblasts, if they've reduced, then we'll have less collagen. Fibroblasts that also produce our elastic fibers will produce less elastic fibers, therefore you won't have your skin be as stretchy. If your skin is less stretchy, we'll start to see wrinkle formation occurring. We'll have less immune cells in our skin. Remember those dendritic cells or those Langerhans cells that we saw in the stratum spinosum, right? And in some cases, you'll see them in the stratum granulosum. So we see fewer of those, makes you more prone to infection if something penetrates the skin there. And then we'll see with our hair follicles, right? We'll see in older individuals, thinner hair. Right? And again, that's because it's just slower and longer to produce that tissue, and maybe we might not get any hair because maybe those hair follicles become inactive overall. All right, some of the other things that you're going to see. If you are in an area, especially if you're closer to the equator, you're going to be exposed to more ultraviolet radiation here. And if you're exposed to more ultraviolet radiation, you increase the risk of skin cancer. Smoking will also help to increase some of these issues here. And of course, I mentioned this before, that ultraviolet radiation can damage the DNA, literally splices that DNA in the nucleus there, and that can give the appearance. And again, this doesn't apply to everybody, but you've seen in certain individuals that smoke, for example, and a chronic smoker. I'm not talking about somebody that's a social smoker, like they go out for a few drinks, they have a couple cigarettes. All right, I'm talking about the people that smoke 2 packs a day. All right, those people, and they've been doing it for years. Right. You might be talking to one of them and they're like, hey, all right, I got to get going. Me and my friends are going to go celebrate my 40th birthday this weekend. And you're looking at them like, you're 40? You look like you're 60. All right. And again, I'm exaggerating. But point being is it does accelerate the aging process there. But the big thing is when we're talking about smoking, again, I'm not doing a PSA, public service announcement or anything, but you have to be careful, especially with skin cancer. I mentioned this to you guys before. Skin cancer is the most common type of cancer. It's 5 times more common in women than breast cancer. It's 5 times more common in men than prostate cancer. It is the most common type of skin cancer, or cancer, excuse me, overall. And it's going to be, all right, I can't tell you how many times when I'm going through a patient history that they have a history in my older patients of basal cell carcinoma or melanoma. And those are some of the commonly associated skin cancers from overexposure to ultraviolet radiation. And so where would we see these cancers? On the head and neck. Why? Because they're exposed to the sunlight more. Yes, ma'am. Yeah. Yeah. Do you know what kind that she had? Yeah. Yeah. And that's and hers probably metastasized. And so that's one of the things that, and certain skin cancers have a higher rate of metastasis than others, and which is I'm going to talk about here. Right. When you see here on this slide, you got basal cell, squamous cell carcinoma, and then malignant melanoma. Right. These last two, and Skylar, this is what I'm thinking. She either had probably squamous cell, maybe not the malignant melanoma, but anyways, malignant melanoma, this is the one that you have to be careful of because again, well, you have to be careful of all of them, right? When you go to the dermatologist, they'll analyze and usually take a sample of the tumor to determine what type of skin cancer. I had a friend of mine, they had this growth on their leg and they weren't sure, of course. First thing they thought was cancer. And they went and saw their primary care physician, and the primary care physician was like, well, I'm not really quite sure, but they're thinking, I'm thinking that might be cancer. This person's freaking out. So they went to the dermatologist, they had the skin biopsy done, and it ended up being what they call dermatofibroma. That's for whatever reasons, the fibroblasts in that area of the skin just started to get buck wild and just start making lots of collagen. And that's what they did. And it looked like a tumor cell, not a tumor cell. It looked like a skin. It almost looked like the basal cell carcinoma here. It looked pretty much. It had like a crater-like appearance there, and that's what they were worried about. But it just happened to be, and that's what that person had. That dermatofibroma, that was benign tumor, right? You know, nothing to be worried about. With these other ones, you have to be careful. Basal cell, if any of these are left long enough, they could potentially metastasize. So what metastasis means is the cancer occurs in a primary location, and then it can spread to other areas. There's different ways that it can spread, right? Take a pathology course to find out what those ways are, right? But there's different ways for that cancer to spread. And when it does, then it's what we refer to as metastasized. It's moved to a different location there. All right, almost done, I promise you. All right. Last clinical view here, Botox and wrinkles. About 20 years ago, I thought Botox, people that got Botox were vain. I don't think that now, all right? I'm all about Botox, but for a couple other reasons here, all right? Yes, most people will use Botox, all right, for the aesthetic features. It helps to decrease wrinkles. And the reason why Botox is one of the most deadliest toxins, and we found a way to inject it into our bodies, all right? But it is one of the most deadliest toxins. It comes from this specific strain of bacteria, Clostridium botulinum. right? And so what essentially it is, it's the toxin itself, right? So we took this toxin, we inject it into the skin, and it literally will paralyze the muscles there, okay? Because it blocks the nerve, right? So if we block the nerve, then the nerve signal can't get to the muscles, and so the muscles relax, and so you won't have wrinkles. The reason why most people have wrinkles, like in their forehead, like I know I do, is because I'm constantly squinching up my muscles up there, and so they're contracting more. So essentially, this causes them to relax, right? And so again, it won't last too long, depending on what type of injection that you're getting. It can last for a couple of months, right? And I had a friend of mine that actually went and did Botox. And the first question I said, "Will you do me a favor? Will you ask your doctor if you once you start this, you have to keep doing it?" You know, and they didn't really answer the question. So the jury's still out on that. Once you start, you might not be able to stop. I don't know. But anyways, well, see, and thank you for bringing that up. Yep. And yep. And I meant to tell you, yes. Botox, and this is what helped to change my opinion on Botox because of that, because it helps with migraines, because it does paralyze the muscles, because some people get muscle tension headaches. And some of you know what I'm talking about. When you get stressed, you'll start to feel pain throughout your head. It helps with that, right? I had a patient, she had a case of what was called idiopathic cervical torticollis. What does that mean? Essentially, and I can't demonstrate it because I don't have the flexibility. When she first met me, her head was laying on her shoulder. It was the darndest thing. Yep. And the muscles in her head, because we took x-rays and there was nothing wrong with the bones there, but the muscles on her neck had gotten so tight and had gone into such spasm, it became a permanent thing, and she could not move her head off of her shoulder. I mean, she had a little bit of motion looking around, all right? But it was pretty much, and again, I'm exaggerating, but it was almost pretty much laying on her shoulder. So we did lots of therapy. After months and months and months, I got her probably to about 30 degrees like this. I just could not get her any further. So about a year later, she comes into the office and she looks like all of us. Her head's straight up and down. She's looking around. I said, "What happened?" Botox. She got Botox, injected it into the neck muscles there, paralyzed the neck muscles. They were finally able to relax. And then she did some more physical therapy and treatment, and she managed to get her neck fully upright. It was really cool, really cool. So, and you'll see, you can ask. There's doctors, orthopedists and whatnot. They'll inject Botox into muscle groups, all right, that are chronically contracting or in muscle spasm, paralyzes the muscles. It's great treatment, great treatment. So, what is the active form of vitamin D? Yep, calcitriol. Calcidiol is an intermediate. That's what the liver makes. All right. So where is calcitriol made? Kidneys. That's right. Good. All right, y'all. Good. Thank you very much for bearing with me and let me wrap up this material here.